Good evening, everyone. Welcome to Red Saree's webinar. Red Saree's mission is to promote a healthier and happier lifestyle for South Asians. Our vision is to improve the overall health and well-being of South Asians through outreach and education efforts designed to implement a comprehensive strategy of healthy diet, moderate exercise, good sleeping habits, and excellent mental health. In keeping with Red Saree's mission and vision, our webinar tonight is Diabetes and the South Asian, presented by Dr. Shailendra Patel. Dr. Patel is a professor of medicine, Division of Endocrinology, Diabetes and Metabolism at University of Cincinnati. Before we start the webinar, just a few housekeeping rules. Your lines are muted. You can submit questions at any time by using the chat window, and for those watching on Facebook, by posting on the comments section. Today's presentation will be interactive. Please do take notes and submit your questions. Today's webinar will run for approximately 60 minutes. This webinar is being recorded. The recording will be made available on Red Saree's Facebook and YouTube channels. Breaks are not scheduled, but if you do need a break, please feel free to excuse yourself. And now it is my honor to invite Dr. Patel to present for Red Saree. Thank you, Dr. Patel.
Thank you, Lata, and thank you to Sakti Sadiappan and the Red Saree organization for asking me to be part of this amazing initiative. I think it's something that grassroots is really the best way to go when you want to make a change. I have decided, I was asked to give a talk, and typically most people would have given you a very polished PowerPoint. As you can imagine, I've been giving talks like this for the last 40 years, and I could easily give you one of my class PowerPoint presentations, which would have been impressive, and you would have said, oh yeah, great, except I've learned that the best way to reach out is to have people listen, focus, and pay attention to what's being said. So you're not going to get a PowerPoint presentation unless there's something I really want to show you that says, hey, let me share my screen and do this. Today we're going to talk about diabetes, and I want this to be fully interactive. If you have access to someone who is an expert at endocrinology, what are your concerns? What would you worry about? What would you like to do? And what do you want to know about? I can give you initially just a quick summary of what diabetes means to a physician like myself, who has been taking care of patients for a very long time. And as a scientist, because of research that we do, that what it means at the bench, what it means at the bedside, what's coming down the pipeline, etc. But what is really important, if you ever want this to make an impact in your everyday lives, is what are your concerns that you need clarification on. So I'll start by giving a little scenario of what diabetes is. Everybody has an idea of what diabetes is. And most of the time when I talk to my patients, the one word that usually comes up, it's my blood sugar, right? So everybody thinks that diabetes is about blood sugar. And that is not wrong, but it is definitely not the story. Some of you may not know a very sort of thoughtful scientist called Minkowski. And Minkowski proposed, what if, and I can't forget who it was, he said, someone who had actually invented or been given the credit for diabetes. He said, what if this person had become egoistic when he was trying to diagnose diabetes? Egoistic means that obviously you lose your sense of taste. And just as a historical perspective, the way sugar diabetes comes along is that someone sort of found that the urine actually was sweet, right? So that means someone must have tasted the urine. And obviously that means that if you can taste sugar, you think, oh, this patient's got diabetes because I tasted their urine and it's sweet. Sounds gross right now, but trust me, worse things, doctors have done worse things than that. And Minkowski said, what if people had been egoistic? What if Minkowski had been egoistic, right? So Minkowski is the guy who said, this is sugar diabetes, and it's got sugar in the urine. Had he not been, if he had been egoistic, but he wanted to know what was going on with the patient, he might have smelled that there are ketones and fatty acid products that were actually in the urine. And if you think about it, all of us think diabetes is about sugar. Diabetes is not just about sugar. Diabetes is a metabolic disorder. For years, we have focused on glucose. I may be one of the few people who um, really disagrees on the emphasis we put on glucose. Now, of course, I have a prejudice. I come from the cholesterol background. I work on atherosclerosis, and I've often said that people don't get the point that what kills most of my patients with diabetes is cardiovascular disease. It's not that they're going to go blind or have kidney failure. Now, that's not true. There are patients that are a subpopulation that we worry about, but diabetes is a metabolic disorder, and the emphasis on sugar that's been placed by the world, by the authorities, by the people who say this is what diabetes control looks like, focused on glucose control. Everybody wanted glucose control. Glucose control is important, but it's a metabolic disorder. Your fatty acid metabolism is out of whack. Your cholesterol metabolism is out of whack. There are other molecules that are also gone. And I think that for the lay person, for those people that say, what does it mean for me to have diabetes? I may have to step back a little and think about what I'm being asked. So I'll give you a quick example of how we classify diabetes, right? So 85% of people who have the label diabetes are going to have type 2 diabetes. That's diabetes that they get in relatively older age. They tend to be overweight. They tend to be insulin resistant. They tend to have poor blood pressure control. They tend to have higher triglycerides. And then clearly they have high levels of blood glucose, right? So that's type 2, 85%. And that may be the vast majority of you. What I'm not going to talk about today, because it is very important, but it's actually a different kind of metabolic disorder, is type 1 diabetes. Type 1 diabetes is really about an autoimmune attack on the cells that make insulin in your body. So here the people really start out much younger, anywhere from literally babies all the way up to young adults. And the peak incidence of when you declare type 1 diabetes is typically the adolescent, by the way. Right? So type 1 is an autoimmune disorder. If you think about rheumatoid arthritis, psoriasis, those are autoimmune disorders. Type 1 is actually in the same vein. And for type 1, they present quickly. Boom, boom, boom. They are fine up until usually about a week. And within a week, they declare that they've got a problem. Type 2 is the insidious problem. So for most of us, it's type 2 that we need to worry about. And it's type 2 that we need to say, okay, what do I want to know and why do I get it? So both type 1 and type 2 diabetes are genetic. There's no doubt about that. Actually, if you think about every disease that we have in the world, there are very few where there isn't some form of genetic predisposition. We have tendencies where some of our genes make us a little bit more susceptible to certain things. So yes, we all have genetic predisposition. And every one of the genetic screens that people have done for both type 1 and type 2, for the type 1s, they go to the immune pathway primarily. For type 2s, they go to the beta cell, the cells that make insulin. And so we know that genes make us susceptible. But I'm going to share with you a couple of facts. If you went back 200 years and asked the question, what percentage of the population has type 2 diabetes? You'd come up with a number. It would be probably less than 2 or 3%. 200 years later, ask and say, what percentage of population has type 2 diabetes? And in America, for example, we have about 25, 30 million people with type 2 diabetes out of a population of 300 million. So at least 8 to 10%. So genetics doesn't change in a very short period of time. By that, I mean that all of the genes that we have that we inherited, for any gene to suddenly become the big predisposing gene, it takes several generations. So how is it that we suddenly went from no diabetes to diabetes? And how do we know that's true? Because if you look at cultures where they had no diabetes and then they modernized, the rates of diabetes exploded. So I'm going to talk about two cultures where we are really very confident about how this works. So the word Apache is probably not the word that Native Americans would use. But if you look at the Apaches that live in the southwestern part of the United States, actually their territory encompasses both Mexico, parts of Mexico, and parts of southwestern USA. And before the borders were drawn, there were no borders like that. They lived on either side. Once the borders were drawn and the two countries separated and one modernized and became much more rich, whereas the other was a little bit more behind in terms of moving forward. The same people were divided by a artificial political line. And what happened? So the Pima Indians are the native Apache, right? They live in Arizona. If you now look at the Pima Indians, who are genetically the same group of people as the Native Americans that live on the other side in Mexico, the obesity rate in the Pima Indians is 60%. The prevalence of diabetes is about 60%, 70%. All right. If you go to their brothers and sisters on the other side of the border, their obesity rates are still 5 to 10%. And the diabetes is less than 2%. Same genetics, different environment, and you got diabetes. This group, the Red Saree, is about South Asians. I don't like the term South Asians because I think that it's not really accurate enough. But for want of a better word, if you look at South Asians and you go to, let's say, parts of India, and you say, okay, let me talk about diabetes. Let me talk about urbanization. Let me talk about the rural areas. And let me talk about the migration of people from one part to the other and what happens. Actually, this story has also been repeated. People who were still living off the land, worked hard, were thin, their level of diabetes is a lot less than the people who became city dwellers, started eating the different kinds of diets, the level of activity is different, and they develop diabetes. Same genetics, environment. So the first point to talk about when we come to talk about diabetes is environment. Environment trumps genetics, but it can do so in both ways. If you improve your environment, even if you're dealt a bad set of genetic markers in your genome, you do not need to get the disease. On the other hand, if you actually have a bad environment, whether you have good genes or not, you may be predisposed to a disease. So this is really probably the key takeaway point of diabetes today. If you ever are unlucky to have developed diabetes or be given a diagnosis of diabetes, and there are ways, I mean, the physicians have their own little criteria for saying, here's why you have diabetes, you meet these criteria, yada, yada. That's scientific. But from a personal point of view, you can do a lot more. And why can you do a lot more? So I'll tell you about another set of experiments, and these were interventional. So we have what's called a phase of prediabetes, because I told you that this is a metabolic disease. So I can pretty much predict the risk if you're high for getting diabetes if you have certain changes in your blood, in your body weight, in your physique, in your activity, in your diet. And we put it all together and say, if I took 100 of you, 50% of you are going to get diabetes in the next 5 years because you have all of the markers and all of the risks that says this is where you're headed. So that's exactly what the US government did, the NIH, in a clinical trial. But before that, actually, the Northern Europeans, the Finns, did a study. And they took the same group of people in either countries, different population, of course, but they had these predispositions that says, you keep going down this line, you're going to get diabetes in 5 years. And the two studies were a little different. They both actually said, you're overweight, you're obese, you got blood pressure, your diet's not bad or not good, and we are going to actively try and do something. So what did they do? They randomized people. To one group, they said, go see your doctor, get the best advice, see what they say, yada, yada, yada. Come and see me, and I'll take your money, see you in the clinic, advise you about diet, lifestyle, like we all do. The other group, after the doctor had seen them, they intensively went back in and said, we're going to call you every week. We're going to give you what you're doing. We're going to get on your case. We're going to make sure that you exercise. We're going to make sure that you're losing weight. We're really going to be intensive. So they both got the same advice that the standard doctors give you. And guess what? The intensive lifestyle changes that were imposed on the Northern Europeans who were in the study, 50% less diabetes in 5 years. They did not develop diabetes. That says that the environment was changed and they could do that. The US trial was a little different because we did use a drug called metformin that we randomized. But again, when the data were analyzed, the huge amount of change was all the people that adhered to the lifestyle, lost weight, ate better, got rid of some of the foods that they were actually predisposed to, and changed their metabolic profile. So you can prevent type 2 diabetes. That's what it said. So for Asians, we have diabetes. So there's the scientific background. Environment is a major factor. The third fact that I want to share with you. People are not all the same. We do have differences depending upon where you originate. And so there is this fantastic investigator from Canada called Salim Yusuf. Great scientist. I mean, he's still very active. And he did this multi-country study. And he went out and said, okay, we're going to go out. And his motive for doing this was to say, just like Red Saree says, oh my God, cardiovascular disease and our Asians are dying quickly of heart disease. Oh, there must be something really bad about it or whatever. And Salim asked a very wonderful question. He said, are the conventional risk factors that we have identified primarily studying Caucasian populations, white populations? And we've got all of this stuff, right? So we know about cholesterol, LDL cholesterol, blood pressure, diabetes. Do they apply? And if so, is that true? Because there was a story that people said, oh, no, these conventional risk factors don't apply to people who are brown, you know, or black or Chinese, because that's not true. And lo and behold, he said, no, that's not true. The same risk factors apply to all of us. We are, at the end of the day, biological human beings. And what separates us is not anything major. Okay. Most of us in different parts of the country, different parts of the world, we have similar predispositions. But there were some subtle differences. One of them is that for an Asian to develop the same characteristics of obesity, they do it with 2 points lower on average, 1.52, maybe even 2 point something lower than a Caucasian. So if I told you that overweight in America is defined as a BMI of 25 to 30, for Asians, this is not 25 to 30. You may go to your doctor right now and they may say, oh, you're not overweight and your BMI is 24.5. Turns out, actually, you are overweight for an Asian. If you are Asian, that's a high BMI because your BMI should be 2 or 3 points lower. And if you do that, every single conventional risk factor applies to you. So your obesity propensity, by the way, so those of you that may be overweight, actually, your overweight may be already verging on to obesity, whereas a white guy may have an obesity that says it starts at a BMI of 30. But someone who is 28 as an Asian, you're obese. You're not overweight. So these things, there are some subtle differences that people need to worry about. So that is like the metabolic groundwork. Finally, the other thing that we know, and this applies to all human beings, it's not race specific. Diabetes probably develops 10 to 15 years before you fully declare as diabetes. So your blood glucose, as it's slowly rising, stays in a relatively normal range because there are many compensatory pathways that are being activated until, if you like, the dam bursts, right? But behind it, that pressure building. And we know about these because we can measure some of these things. So we know that about 10 to 25% of people who present with a diagnosis of diabetes for the first time ever already have complications of diabetes like neuropathy, retinopathy, a little bit of kidney impairment, because it's probably been going on for 10 years. So that's the other thing. It's hidden. You don't even know it. You may be sitting listening to this video chat today, and you could be one of those people. So you do need to pay attention to what you look like in the mirror. I do have a slide when I give one of my Polish talks, and actually it's about two scientists. Both, one of them is a friend, the other one I only know as an acquaintance. One is a white guy, well-known scientist in diabetes. The other is an Indian who is absolutely well-known in diabetes as well. One works in Pune, one works in England. Well-known scientists, and they both are relatively thin, except the white guy has a little higher BMI than the Asian guy, but the Asian guy is pretty good. They both underwent an MRI, magnetic resonance imaging. They imaged their abdomen and they said, okay, what do you look like? And the surprise was the Asian guy had more fat inside his abdomen, right? The kind of fat that we metabolically now know as harmful than the white guy. So even though he looked slimmer for his age and matched, because they're both very similar, he actually had a worse metabolic MRI. So for Asians, we know that your BMI needs to be lower because every time you get fat, you put on the fat in the right. So fat is not all the same. There are different kinds of fat. Fat is not fat. Fat is actually metabolically active, and it depends upon where it is. There's subcutaneous fat, there's retroperitoneal fat, there's intraperitoneal fat. All of these different kinds of fat are not the same. And the fat that you have inside your abdomen is actually the worst kind of fat that you can get from an inflammatory process. Just by having it, that's not a bad idea. We all need it. It serves a purpose. But if you suddenly start to get a lot more of it, right? So it's the excess of it, it starts changing metabolism. Fat can actually elaborate factors that change your hormones that control your blood pressure, for example. They can certainly change hormones that control sex function too, in both cases. Because they have enzymes and things that they do in terms of metabolism. They can change glucose as well as carbohydrate, as well as fat metabolism. So you already have that level of change. If that's all happening, why are we not all dropping down with diabetes? Because we don't all have a universally bad have it all the time. We have it in spurts, right? Most of us eat well, but then most of us every now and again will do more than we would like to do. Um, most of us will overeat calories. It is part of life. We call them um, comfort foods for a very good reason. When we're stressed, we are going to eat as part of our comfort. All of us do. And we need to recognize that if we want to change our environment, we can certainly take comfort from food, but we also have to make sure that it's in moderation. So, this talk is about diabetes, but it's actually about lifestyle. This is all about lifestyle. It is not about glucose. So, as you can see, I've talked for a while, and yet the one thing I've not talked to you about is glucose. And I think that from a diabetes point of view, that's how it should be. Lifestyle absolutely is the key basis for all of this. And controlling lifestyle will make you go a long ways. Now, I'm talking about the vast majority of Asians where the lifestyle changes apply. For the few of you that have diabetes, that have it's already established, it's a diagnosis, it's not reversible at this stage, it's a different matter, and that's a conversation we can have. And I'm happy to actually be interrupted, have questions, and I really would want to welcome the dialogue, okay, rather than this be a monologue. But we know what we have to do as one, a community, two, as an individual, all right? So, from an individual standpoint, things that are important to us. Sleep. Actually, Lata mentioned sleep. I think sleep is really important. Underrated, but important. You don't need a lot of sleep, but you need what we call unbroken sleep that allows you to get into that REM phase at some point and let you get into that deep phase before you waken up. If your sleep's broken up, you never get down deep. And actually, studies have shown that if you take anybody who is a superb at anything, doesn't matter, mathematician, athlete, if they don't sleep well, their performance at that high level is actually degraded. In fact, one of the famous stories for sleep goes with, I can't remember which one of the football teams, Tampa Bay or whichever of the Florida teams was, I actually hired a sleep analyst for their players to actually make them perform better on the field. Because once they got them to sleep better, turned out that they played better. That applies to mental function. So we know that that is important. So sleep is important. Diet. We eat a lot of convenience foods. We eat a lot of processed foods. We do it because, as the word says, convenience. When you buy something that is not processed, to make it work in the kitchen is a lot more work than what you can do is just pour it out of a bag and cook with it, or even perhaps if it's already pre-prepared, eat it. That in itself is part of the problem because we were not engineered genetically or biologically to actually act that way. I have a rule. I tell patients, Dr. Patel's rule, eat fruit, don't drink them. And they all look at me when I first tell them that. And then I tell them why I say that. So I said, look, if I gave you 6 oranges in a row and I want you to eat, I'll cut them up for you, but I want you to eat them all in 3 minutes. Just eat 6 oranges in 3 minutes. And they all go, Dr. Patel, not even going to attempt it. Not going to happen. That's just too much. And then I go, but I bet I could give you 6 oranges in under 3 minutes. And you turn it into orange juice, squeeze it all out, put it in a glass, and you gulp it down. Okay, what's the difference? Biologically, you were meant to eat that orange. So when you cut it up, you eat it, you digest it, you have your food, you chew it, your senses in your mouth stimulate your brain. Your brain is recognizing it. A little bit of that goes in, you're eating it. And then at some point, your brain says, yeah, that's an orange or 2. I can eat 2, but I'm done. I'm good. Your brain's giving you the mechanism. You're fine with 2. And yet when you drink it, you're able to get 6 in. So your metabolism was not engineered genetically to take in 6. It's already got checks and balances when you do it naturally. So you need to listen to these mechanisms. We bypass these mechanisms all the time when we have a lot of processed foods. Don't get me wrong. I don't want to castigate processed foods. There is a place for it. Like everything in life, moderation. But you also need to realize that the modernization of society is not always a good thing. People take it for granted, but they don't question it. I think it's very important to question things like this. Um, and I think that it is very good for people to sort of think about the diet that they eat on a daily basis. Um, I see that there is a question in the chat box. Diabetes, once you have, is not reversible, but there are ways to stay away from getting from meds stage to insulin. Or is that a losing battle that one will eventually end up with insulin injections as you age? Good question. And that was sent by Uma. And I will answer that right now. It is not true to say that diabetes is not reversible. The definition of reversible is a little um, difficult to pin down, but I will give you the scientific evidence. So if you have diabetes, you are clearly overweight, and you undergo bariatric surgery, that is weight loss surgery that makes you lose weight. I will also say that actually, if you can lose the weight by non surgical means, which is very, very hard, it's for another day. That talk about obesity is for another day. But let's just say that I could make you lose dramatically that weight. And we know that bariatric surgery does so. This is a scientific study done all over the world by different centers. If you take type 2 diabetes patients who are overweight, obese, got bariatric surgery, within 5 years, okay, of their diabetes diagnosis, 80% of those patients were on no medications for their blood glucose control, and they did not show that their blood glucose levels rose after they ate food. So the question is no, at that point, diabetes was definitely reversible to that prior phase. So it is not true that you can't reverse diabetes. And that's why I was talking about that pre-diabetes phase. That's why I was talking about that metabolic phase. You catch yourself in that phase, you really can do something. And you must do something because, like I said, 50% of you are going to progress onto diabetes. I agree for that skeptic in the audience. But what about the other 50% that didn't progress? Okay, sure. Not everybody gets diabetes, even when you have all those bad risk factors. True. But the thing is, I can't tell you who that person is. So all I can tell you is what you should be doing. And then, in answer to the second part of Uma's question, if you have diabetes and you are on meds, can you avoid insulin? Yes. The answer is yes. Again, same thing. If you change many of the factors that make your diabetes worse and you begin to control it, your level of progression to insulin is not inexorable. Now, as a doctor, I will tell you that there is no such thing as perfect. So the vast majority of people will certainly do that. Yes, there are people who do all the right things and yet they still get onto insulin. And that is what it is. But a large percentage of people who actually lose weight, control blood pressure, control triglycerides, control the metabolic aspects, will not progress onto insulin. They actually do pretty good. So, no, it is not a lifetime diagnosis that cannot be manipulated. It absolutely can be. But the problem is, it's what you want to do. What will you get out of your comfort zone to commit to when you want to do that? But you have to do it, and it's an individual thing. All of us can probably identify at least one or two of our own relatives who, when they have diabetes and they go, wow, but it's okay, it's only a couple of ladus, I'll be fine, I'll maybe take a little bit more insulin or whatever. And you kind of know that they don't just do it one off, but it's a little bit more frequently. So And we love them. I mean, they're our family, but it's that attitude. Um, I want people to cheat. Actually, I tell my patients, if you don't cheat, you're not human. But I tell them, cheat to make sure that it counts when you want to cheat, right? Make sure that it's on a good occasion and not because you do it all the time. So, no, and answer to your question, environment still trumps once you have disease. And this is true, by the way, of most chronic diseases. There is a pathway to make things better. It's not inexorable. But if you are on insulin, I will tell you that you shouldn't be afraid of insulin. Insulin still remains to this day a very powerful um, medication. Everybody thinks that insulin reduces blood glucose. But trust me, insulin also helps reverse some of the other metabolic changes, like the free fatty acid level that I told you. Minkowski, if Minkowski had been agoistic, he would not have said this is sugar diabetes, this is diabetes caused by sugar. He would have said it's diabetes caused by fatty acids. And insulin also brings down your fatty acid levels in metabolism. I shouldn't say that, that's not scientific. It alters your fatty acid metabolism. So that is really important for people to realize. And I think that you should not be scared. What you should do is to be better informed. So once you have diabetes, get well informed. Dr. Google is now everywhere. Like any physician, I pretty much do hate and love Dr. Google because sometimes it's nice for people to gain some experience and information from Dr. Google that we don't have to spend our time in the office visit. But the other times we're fighting Dr. Google because people go and listen to stuff that is not very scientific as well. Um, so, no, I think that you can get information from all sources. I think it's worth getting it, but I think that the biggest thing you need to do is to make sure that you work with a professional if you have diabetes and start actually paying attention to the advice they're giving you, even if it's a short 20-minute. What did they say and what do they mean? And these days, because of my chart and activities like that, you're more and more you're connected. That sometimes clarification of questions is easy because you just throw in a question and ask. And getting that education, getting that word out. There are probably people you know who clearly are sedentary. Um, all of us need to understand that exercise. People have misconceptions about exercise. Exercise is good for the heart, as they always said. What does that mean? It's for cardiovascular fitness. When you exercise, it's your cardiovascular system that's being given a stress test. And we want that because the more you stress it, the better it gets. You cannot lose weight from exercise. Anybody who thinks that if they go on a weight loss program and say, well, I'm going to exercise my way out, not going to work. Exercise is there for what we call weight maintenance. Your diet allows you to lose weight. And then on the days when, like I told you, you cheat or you have a little extra, it's your exercise that allows you to act as the buffer. I happen to just grab that Mars bar, 300 calories, and I'm going, ugh, it's more than 300 calories that I needed to have today. Yep, 30 minutes on the treadmill, and there's my 300 calories. All right. So I maintain my weight without that Mars bar adding, a couple of ounces of extra weight because I ate it. So the purpose of exercise is weight maintenance. But the biggest impact for exercise is cardiovascular fitness. You exercise your heart, you increase the vascularity, you make more demands of those capillaries to carry more and more oxygen into your muscles in different areas. If and when you do get a blockage, that heart muscle had so many more capillaries because of the exercise that a little blockage here was compensated better by those arteries and capillaries that had actually stayed a little open. So, yeah, you still got a heart attack, but guess what? The muscle damage is a lot less than had you not exercised. So, exercise is kind of like insurance. You need to buy the insurance and you need to do it. So, don't park your car right next door to Kroger's doorstep. Park it a little bit further and walk. It's okay, all right? It's fine because you get your steps in. we have pedometers that people say you need to get, 1,500 to 3,000 steps a day. And most of us are probably going to struggle to get to about 800 to 1,000 a day if we are sedentary. And if you are a sedentary person, you sit at the desk, you're a guy who's mainly behind a desk, then you have to build in every day, or a gal, I shouldn't be sexist, or a gal who's behind a desk, you need to work in to your routine some exercise plan. Do you go to the gym 3 times a week? Do you have a gym in your house that you are happy with? It isn't about gym. When people ask me, what should I do? I tell people there is no such thing as what I want to tell you to do. Exercise is one of those things where you pick what you enjoy. If I tell you to go swimming every day and you hate swimming, you'll do it for a week and you'll give up. So
Dr.
pick the
Yeah.
exercise you want to do. Yep, go ahead, Lata.
There are a couple of questions. Rama asks if statins should be prescribed for people at risk for diabetes.
Okay, I can take that. So, complicated question. Um, if a statin is indicated for a person who is at risk for a heart disease, right? So, the only time you're going to be given a statin, Rama, is when someone says your cholesterol's high, you've done the diet and you're not getting it better, you've got a family history, you've got some risk factors, and we think you're at high risk of cardiovascular disease. Should you get diabetes? Should you get a statin if they have this risk of diabetes, i.e., they're the prediabetes? The unequivocal answer right now is yes. And here's the reason why. So, Rama's question, for those of you that don't know, is when statins were given to people with prediabetes, more people turned into diabetes attributable as a direct consequence of taking the statin, right? So you would not have expected that statin controls your cholesterol, but it tipped you into diabetes. And we see this in clinical trials. But here's the risk benefit calculation. More people who are in that category who need a statin treatment are going to prematurely get a heart attack, stroke, or die from a cardiovascular event than develop diabetes. So, yes, your risk of diabetes does go up a little, but your risk of dying from these other diseases is so much greater that the risk benefit is still in the person who takes a drug for lowering cholesterol. And this risk, I think, is not just with statins, but I think it's with non-statin drugs as well. So I don't think you can get away by taking a PCSK9 antibody to lower your cholesterol, because the genetics of this has been looked at, where you look at the genes that predispose you to cholesterol levels and then ask, do they predispose you to diabetes? And it turns out that it goes with the cholesterol pathway. We don't fully understand why, but it does. So the answer is yes, it does, but no, absolutely. If you need a statin for your cholesterol, take it, because that has got way more evidence in preventing you from dying prematurely than you developing diabetes. And you develop diabetes, guess what? We have great medications and doctors to take care of you. Yes, your cost and insurance goes up a little, but we can take care of you better. So, no. Second question, Lata.
Radha from Facebook asks, some of my meds seem to counteract with each other and cause weight gain. I'm not yet on insulin, and I'm trying to stay as active as I can and watch what I eat always. How can I reverse my 20-plus-year-old diabetes?
Absolutely. So once you've got 20 years of diabetes, rather, I hate to tell you that it's reversible. I don't think it is. I think that there is a window in which you can reverse it, and after that, it usually is a little tough to reverse. But I do think that a good interaction with your provider needs to be had. Yes, it is absolutely true that there are some of our diabetes medications that do lead to weight gain. So the drugs that don't lead to weight gain or are weight neutral, so either they lower it or they don't affect it much, are metformin, drugs that are called DPP-4, like the brand names are Januvia, Nesina. So they're DPP-4 inhibitors that are weight neutral. Um, Sulfonylureas will increase weight. So we're talking about glipizide, gliclazide, glimepiride. Um, Not common, some of these drugs in this country, but certainly that category. Insulin is clearly a weight building drug. It makes your fat take and keep the fatty acids. It doesn't allow it to come in the blood, so the fat cells get a little bigger. So, yes, it's going to make you gain weight if you go on insulin. And then another drug, which I love, by the way, is a drug called pyroglitazone, trade name Actos, it's generic. Pyroglitazone is a wonderful drug, but I tell my patients right off the top that they might gain between 2 to 5 kilograms. So that's 4 to 10 pounds, right, on average. And they look at me and go, "You've been telling me to lose my weight, and you're going to be putting me on a drug that might make me gain weight." And it turns out that pyroglitazone changes the kind of fat. Remember, I told you not all fat is the same. Pyroglitazone changes the fat that is metabolically harmful, and it decreases that, but at the risk of giving you the metabolically inactive fat. So you do gain fat weight. It's not metabolically active. And it turns out that it's associated with increased cardiovascular protection, stroke protection, and obviously diabetes control. So, yeah, some medications do that. Medications that also make you lose weight are the newer injectables. And for rather, you might want to talk to your provider about some of these injectables. They're called GLP-1 receptor agonists, Ozempic, Trulicity, Bydureon. They're the ones that work on your brain, they work on your stomach, they work on your pancreas, and they do make people lose weight up to 10 pounds, 15 pounds of weight loss. So, and they absolutely improve your diabetes because they work in the diabetes pathway. So, worth thinking about. But no, if you get on insulin, it is tough to lose weight once you're on insulin. I will admit to that. And looks like there's another question.
Yes.
What is your comment? This is from Venkatesh. What is your comment on keto diet? If it helps controlling diabetes, can one use it to prevent diabetes? If so, when can one start a keto diet? Oh my goodness. So there are several concepts in here. I'm going to tease it apart. What do I think about the keto diet? Number one, every diet under the sun, is successful. You've heard from me. That's it. Every diet works. So why is it that we are still all fat and can't lose weight? Very simple. Because we go on a diet, we will lose the weight, but we didn't commit to that as a lifestyle. So if I put you on a keto diet, how long are you going to keep it going? Are you going to keep it going for 6 months until you lose the weight to the level that you want, and then go back onto your carbs and whatever you're doing? If you do, you'll lose weight, boom, you're going to increase. South Beach diet, it's going to work. Atkins diet, eat meat, it's going to work. But then you get sick of it. You get sick of seafood and say, I ain't doing the South Beach diet. You get sick of meat and you say, I ain't doing the meat diet. You get sick of the keto diet and say, nope, I need to eat my potatoes and carbs. I'm just dying for this. You didn't change your lifestyle. So if you want to be successful about weight loss, doesn't matter what you pick, commit for a very long time. So I tell my patients, pick a diet that makes you lose weight, but it's something that says if you are like this 3 years from now, 5 years from now, then you'll be successful at keeping your weight off and staying that way. Can you use weight loss to keep diabetes away? Yes. Doesn't matter how you do it. Keto diet, South Beach diet, Atkins diet, you get the weight off. It's about the weight. A large amount of it is because of the weight. You get that weight off and it's going to work for you. So the answer is yes, but it's longevity. Can you keep it going? When can you start a keto diet? Anytime. I mean, a keto diet, I think that a keto diet is harmful? Yes and no. Keto diets can be harmful if the keto diet and the kind of keto diet you're using puts up your cholesterol levels, your LDL cholesterol. If you do put up your LDL cholesterol levels, I mean, it's a risk factor for cardiovascular disease. So now you've got a diet that's actually doing positive on the weight side and a negative on the cardiovascular side. So it's a risk benefit, and it's not easy question to answer. Um, I think that if you monitor it and people says, nope, your other parameters, blood pressure, cholesterol are all good, then I think a keto diet's pretty good. Um, I'm not anti-keto diet. I think it's fine. I think there is a point to it. It can kickstart weight loss, but the key to success is lifestyle. Can you keep it going? Will you promise to keep it going? And you do. That's a winning formula for you. Hopefully that answers your question, but come back to me if that doesn't. Kalpana is asking, I have someone who's gained a lot of medication, a lot of weight from arthritis medication. She's not diabetic, but she certainly gained a lot of weight. Okay. And then there's a family history where there's positive for diabetes and heart problems. So, what can someone do if your physicians, your disease, your background is giving you a lot of weight gain? I mean, it could have been a nasty endocrinologist like me giving you steroids for something that says, hey, you need to take the steroids, and here you are, you gain weight. Um, Sometimes it's very hard. I have to say that it's not something that we can always control. But I think that education is key. Before we start medications that we know are going to lead to weight gain, we start talking to people about saying, you've never thought about calorie control. You've never thought about counting calories. You've never thought about lifestyle like that. You know, you eat when you're hungry and all that. But when we put you on this medication, your appetite's going to be really stimulated. And we're going to need to talk to you about how you have to curb this and what you have to do. So you may have to change the quality of the food you have access to, right? So what do I mean by that? If you're hungry and you eat a piece of cheese, that's a lot of calories. If you're hungry and you eat some celery, guess what? That might even put you in a negative balance because digesting celery is actually causing you to burn more calories than the celery is going to give you. So you need to then start sitting down with a dietitian to say, what are the foods that I want to have in my fridge? So when I get hungry, I open it up and that's all there is, right? So if you don't have all of those high calorie foods in your fridge or in your cupboards, when you're hungry, you ain't going to be able to eat it. So there are these little tools that you try and do to yourself to help you not pick the foods that make you gain more weight. It's not a secret, everybody knows it. The only reason why food is really, really tasty and you love it, it's not the sugar, it's the fat. Trust me on that. If you are a good cook, you know this already, that it's the fat or the fat content in the food that you put in that everybody goes, oh my God, that is so delicious. And it wasn't the sugar that you added, it was the fat. We have taste buds for the fat. So for people who are predisposed to gaining weight or have medications that are gaining weight, you do need to make sure that that calorie access is going to be there. So I really want you to pay attention to the calorie access. You need to pay attention to the kinds of foods you buy. Simple rule, if you are shopping for food, and I think that people do need to be more careful about this. Are you eating a higher fiber, less processed food? Sometimes it doesn't always taste good, but it is what it is, right? You do need to spend attention doing that. So I think you do need to sit down with a dietitian or get educated. And doctors are going to prescribe medications that are going to make you gain weight. But I hope that the good ones are going to start by saying, we're going to put you on this medication, but I want you to spend some quality time with my dietitian who's going to talk to you about what you're eating, what your ethnic food preference is, because you do need a dietitian who understands what you eat every day, right? Because if you don't eat diets that most people eat, you need to have that translated by people who understand that so they can give you better advice about diets. With the internet, of course, I will not be surprised if you can find the dietitian that understands your ethnic food, because I know that people have been doing this in India for a very, very, very long time. And I bet that now they probably even put that on the web. somewhere for you to get access to.
Rama has another question, Dr. Patel.
Sure.
She asks, is there a difference in risk of South Asians living in cities in India versus US, European countries? If so, what is this attributable to?
Oh my, wow, that's a great question. About 18 years ago, actually, I did a tour with my then chair in endocrinology. We went round to India to actually really look at and ask, see if we could partner with some of our collaborators in India to talk about this particular problem. So this is a problem that's been identified for many, many years. This is not new. And the short answer to your question is yes. People who have migrated from rural to urban areas in India had a dramatic upshift in cardiovascular disease. Bypass grafts suddenly started taking up. Stents started taking up. We never had that level of epidemiology before all of these migrations. But at the same time, it wasn't just migration. It's a complicated story because so many factors have changed. The ability to have access to different kinds of foods have changed, so that the stuff that rural people ate is very different to what people in cities eat. The access to food, the refined oils that you can actually also eat in cities also changed. And then, of course, and this is, this has been studied in different populations, and it's still an issue. Pollution. People forget that the diesel engines, the particulate matter has been shown to also increase cardiovascular disease. Now, of course, this doesn't pertain to diabetes per se. This is more for cardiovascular disease and lung disease, but it is still an environmental effect. So the answer to your question is yes, there is a difference. Is there a difference between people living in cities in Delhi, Mumbai, Bangalore, to people who live in New York, San Francisco, Cincinnati? Environment does matter, but whether it is going to be easy to dissect is going to be tough. I can give you some historical perspectives, but they're historical. So the migration of the Japanese from Japan has traditionally had a very low incidence of cardiovascular disease to Hawaii, and from Hawaii to the mainland. And you can see a progression of an increased incidence of cardiovascular disease in these groups of people. All they did was emigrate. They didn't change their genes, but they clearly changed their environment. They clearly changed some aspects of their food. They didn't change all of their aspects of the food, but they clearly didn't eat like mainland Japanese. But yet, if you now look at that, it clearly changed. And you see the same progression. You see this very same progression in many of the people from rural India who emigrated to a westernized society. And you see the same illnesses that they start to normalize to the white Caucasian high level of cardiovascular diabetes incidence, even though they came from villages where they didn't have much. Yes, it does occur. And yes, it is environment. But the factors are not easy. I wish I could tell you that it was one thing or the other. People have talked about their favorite thing, but I suspect it's multifactorial.
And Shakti has a question. He says some people have diabetes very early in their life, like before 35 years of age, and some have it later in life. What makes these differences? Are there factors that aggravate the presence of diabetes early in life?
Well, first thing, Shakti, good morning. I think you told me it's like 5:30, 6 o'clock in India. So thank you for joining us. In terms of your question, so I mentioned early on, and then I didn't go into details. I told you, there's type 1, there's type 2. Actually, diabetes is really a big catchment, and there are different kinds of diabetes. So there's diabetes that you can develop very young, even though it's not autoimmune, right? So it's monogenic, single gene disorder. It behaves quite differently to type 2 diabetes. The risk of certain complications are different. We can even though if you've been put on insulin because you got it at the age of 9 or 10, you can actually come on pills because the kind of diabetes you have says Throw away your insulin, you'll be fine on pills, and here you go. And you need the amazingly tiniest amount of pills, certain kinds of pills to control you. If you develop it younger, then the genetic risk factors are greater in terms of their activity in you than when you develop it later. So yes, there is a difference between people who develop it younger and people who develop it older, right? So that genetic predisposition is there. And we certainly have evidence that these people carry greater variance in certain genes. If you ask me how many genes are involved in someone getting type 2 diabetes or early diabetes, so if you do genome-wide scans, we can now sequence people very easily and look at the genetic variations. And if you put thousands and thousands and thousands of people together, you can actually ask statistically significant questions like that. And it turns out that you probably need a minimum of 20, 30, 40, 50 to 150 genes that are different for you to be predisposed. So you can imagine your diabetes is not that simple. It's complicated. All right, I heard something in my ear going, your hour is up. Is that right, Leta?
No. Well, the questions are over, but then I have a question, though.
Absolutely.
So generally, when you go for like a blood work, they do the blood glucose.
Yes.
But then, I've also heard of A1C, which usually doesn't really show up on the regular blood work. So
correct.
When should you insist on A1C? So, or is the A1C generally suggested when the blood glucose is at a certain level?
Yeah. So let me give you a quick history of diabetes. And this is now more than you ever wanted to know. So way before A1C was ever invented, our definition of diabetes was very simple. If your blood glucose when you were fasting on 2 or 3 occasions was greater than 126, you have diabetes. Or if you were given an oral glucose tolerance test, so we said here, drink this 75 grams of glucose very quickly, yucky, 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 and then 2 hours later, your sugar should be less than 200 milligrams per deciliter in the American system, as opposed to the SI units. You have diabetes. And for ages, we managed blood sugar by actually testing your urine and saying if you didn't have sugar in your urine spilled over, your diabetes control is great. And then people realized it wasn't very good. So they came up saying, how do we measure glucose and measure control? And they tested, and then finally one method that stuck was this A1C, hemoglobin A1C. So how does that work? All of us have blood glucose. And the glucose, it doesn't matter whether you are normal, even if you don't have diabetes. If you have any sugar, the glucose in a chemical reaction wants to permanently bind to a certain kind of amino acid on your protein. Okay? The way I explain it to people is, and some of you may be vegetarians, so if you get offended, I'm sorry. But if you want to make that picture perfect turkey, right? That Christmas picture perfect turkey that comes out of the oven and it's that lovely brown sheen that comes out nice and roasted on the outside. How do you do it? It's very simple. You baste the sugar, the turkey with sugar on the outside. And when you put it in the oven, the high temperature makes the glucose in the sugar bind to the protein in the skin and caramelizes it like that. Okay? Well, it turns out that you don't need temperature in your body to do that. And the glucose binds to the hemoglobin in your red blood cell and binds it. So I don't have diabetes, but my A1C probably is, 5.5%. So 5.5% of my hemoglobin already has glucose attached to it. If you have diabetes, on average, your sugar is higher and higher and higher. So more and more of your red blood cell hemoglobin gets glycosylated. And so it may go from 5.6 to 6 to 6.5 to 7. And so the American Diabetes Association one day came up and said, well, anybody who's got an A1C that's more than 6.5, yeah, we'll call you diabetes. And between 5 point something and 6.5, your prediabetes. So in answer to your question, Lata, yeah, you could get an A1C test done. And why is the A1C test more accurate? It isn't. It's just a convenient way. It doesn't mean you have it. And then there are some nuances. You have to realize that this is absolutely based on knowing your race and your identity and your red blood cell turnover. So, for example, an A1C of a certain number in an African American doesn't mean that their average blood sugar was exactly what it would be in a Caucasian with the same A1C, because the red blood cell turnover are different as a population. And even in individuals, two Asians could have different A1C numbers, but the same average glucose. So it's not easy, but as a screening test, I think it's fine doing. I think if your primary care wants to order it, the major societies in the U.S. have said yes, you can do it, and so yeah, your primary care can order it. The gold standards are still going to remain fasting blood glucose on two occasions, and certainly an oral glucose tolerance test. But no, I think if your A1C is more than 6.5, you definitely need attention. I think if you're at 6.5, you need lifestyle changes. I think you're below 6, I think you're doing pretty good.
Okay. Uma has another question. She says, I hear the morning fasting reading seems hardest to lower. Are there specific things we need to get that down?
Yeah, so I didn't talk to you about all of the reasons why you have this, right? So I told you that diabetes is a metabolic disorder. Okay, so fact number one, every human brain, the one thing the human brain needs as calories, what it feeds on, what it works on, the vast majority of time is glucose. All right. So your body needs to make glucose for your brain. And everybody thinks that this, that, and the other about what makes their bodies work. I'm going to tell you that the only reason you exist is to serve your brain. If your brain wants it some way, it will take every aspect of you and make it so that it can get stuff. So the purpose of the brain is to make the liver make glucose. Normally, we have mechanisms that say, okay, you can get glucose, but we're not going to give you, a huge amount. So when you develop diabetes, what happens is that those mechanisms don't exist. The brain, on the other hand, could not care less if your blood sugar is 300. So it has no mechanisms to make it go down. It does not care. So diabetes makes your liver make glucose unregulated. Normally, your insulin would come in overnight and say, oh, yeah, the brain needs glucose, but once we get to this level, it's good. But when you have diabetes, the sugar goes up. So your morning glucose, Uma, is high, not because you snuck out of bed and ate a meal. No, absolutely no. It's because your liver did not listen to the insulin from your pancreas, because that's part of your diabetes defect. And it continued to make glucose because its purpose is to make glucose for the brain. So your brain's happy, but the rest of your body isn't. It is tough to control. And yes, there are tricks to the trade. A very good one, and this is one of the few times where it works beautifully, is a little bit of bedtime insulin. Because that bedtime insulin tells your liver, okay, buddy, switch off. And you titrate it. The dose of your bedtime insulin is titrated to what you wake up in the morning. So I tell my patients, start on this dose, and then every 2 days, if you see that that number hasn't come down, increase your insulin by a couple more units. And keep doing every 2 or 3 days, 3 days, 4 days, whatever your comfort zone is, until you wake up with a great blood sugar. And that's your bedtime dose that you need to do to switch off that liver from making glucose. And the liver's making glucose because it's serving its master, the brain. That's it. That's why that's occurring. And we have other mechanisms for also doing that with the liver, but insulin's a pretty good one.
Okay. That's all I see. Does anyone have any other questions? Does fasting 16 hours help diabetes? Rama's asking.
Yes. So fasting has a lot of benefits. So it turns out that intermittent fasting, fasting for a day, has also been shown to actually be very, very helpful. It's funny how the wheel turns and you come back to what your grandma used to tell you, right? I mean, everybody on this audience is Asian in terms of, oh, you had a day of fast, right, that you had to do for God or whatever. I'm not godly, so I don't care, but I will tell you that that myth may have come from somewhere because it was found somewhere through experience of human nature that fasting was actually beneficial for health. And I think that that's how it gets into most people's cultures. If you look, that concept of fasting is in many human cultures. And when things like that evolve, sometimes you don't want to poo poo it. You want to say, okay, what's the benefit? And the answer is when scientifically people have looked at it, fasting is definitely helpful. However, you also need to be cognizant of the fact that when you starve and you have a weight problem, you end up breaking that fast by overeating. So, fasting when you don't have issues like that are good. But when you have an issue where diet control is an issue, remember that going the other side makes things worse, not better. But no, for most of us, where I think that you're looking to make things better, I think it's fine. And on the same token, and this is a bugger with me, we evolved in a very different way. We evolved that our meals, and actually, if you look at your relatives who grew up on farms a generation or two back, this is exactly what they did. They had bigger meals at breakfast and maybe lunch, and they had what sounds like breakfast for dinner. What do we do now? We do the complete utter opposite. You run out of the house with a cup of coffee and maybe a bagel or whatever in your hand, and then you come home at 6 and have this massive meal, and then 3 hours later you're in bed. And we have turned the table. So our metabolism was not meant that way. If you eat the same number of calories, but you eat the calories in the evening in the way I suggested, turns out you gain weight, but you eat the same calories, but you eat most of it in the morning, you don't gain weight. So calories eaten at breakfast are actually less obesogenic than calories eaten at dinner. So there are two aspects to that question that you asked. It's a good question, but it's lifestyle again. And how do we break that cycle? Because we need to change our eating habits. If I told you that you need to now eat more at breakfast and eat a very, very light dinner, most of you are going to get uncomfortable. But if you can break through and make that habit, it might be beneficial. Okay. Back to you, Lata.
What should a resting glucose level be for normal people between meals, for example?
Always. So so for normal people, you don't need to worry because you've got mechanisms in your body. I mean, you've got about nine different hormones that are looking at your blood glucose. And in general, one, you shouldn't be checking it. But if you happen to have diabetes, I will tell you what it should be. In between meals, you should aim for that sugar to be less than 130. Okay. If you don't have any disease, and you are completely normal, in between meals, your sugar really should be close to 100, all right, or below. You really should not have 150. If you're hitting 150, I think you're pre-diabetic for sure, all right, because you're not putting your stuff away quickly. But that's for a normal person. But for a person with diabetes, which I think this is talking about, you want to aim for it to be less than 130, whichever way your medications and stuff work. I think that's a good number to go for.
Okay. That is all I see at this time. Does anyone have any other questions? Are Indians more prone to fat mass than muscle mass in spite of workout? Kalpana is asking.
And difficult question to answer because I don't think anybody's ever studied a question like that in a race-based way. Um, if I fall back on my scientific hat, the answer's got to be no. I think we are all human beings with the same metabolism, the same genetics, the same basic biochemistry, and I think that um, we're not going to gain more fat despite the workout. We're going to gain more of it because of our diet. I think diet is a bigger key than the exercise. I know fit people who are fat, and I also know fit people who are thin. And I know fit people who are Asians who are very muscular. And I think that it depends upon the diet. Um, some foods are more prone to make you lay down fat than others. Um, People who eat more legumes are better off than people who eat more refined carbs. Our diet has a lot of carbs, right? I mean, we eat a lot of refined carbs, and it would be tough to avoid because that's our traditional food sets, right? We really don't have that. Gosh, there's a few questions more coming in. Lata, is that okay if I read them out?
Oh, yes, absolutely.
All right. So there's a
Keyur.
there's a golfer named Keyur who says, "Are people with hypothyroidism more prone to be diabetic?" Yes and no. People with hypothyroidism, if their weight has gained because they were underactive at some point, because hypothyroidism clearly controls the metabolic pathway, and you do gain weight with that, might do it. In general, hypothyroidism is more autoimmune. It is unlikely that you're going to get type 1 diabetes, which would be the one predisposition. But the weight thing, if you gained enough weight, then the answer is yes, because it's connected to the weight. Thyroidism per se will not make you have diabetes, though, but it will be the indirect effect of the weight and then the diabetes. We like to hear from you on doing yoga, and it's oh my goodness, I love Sakti. You are just setting me up today. All right, that's a question from Sakti who says, "We would like to hear from you on doing yoga and its benefits to improve diabetes." Benefits to improve diabetes, maybe, but indirect. Mental health is really important. And let me tell you that there are studies done that show that if you practice meditation or you practice yoga, your blood pressure actually improves. So this has been done. And it's not me saying, oh my God, I like Ayurvedic medicine, or in fact, I don't. I really don't really subscribe to any of that. But I do subscribe to mental health, yoga, well being, stress, reducing stress. And if you reduce stress, you do actually impact factors that also help you with your diabetes. So the answer is it's an indirect thing. There's never going to be a controlled study that says, let's do a randomized placebo controlled study on yoga or transcendental meditation or Tai Chi. But I recommend it to so many of my people because anxiety, depression is really improved by yoga. Because yes, we can talk to you. Yes, we can sometimes prescribe meds. But I think that you can do a lot more by doing these things. And yoga has many more benefits above that mental side. So, diabetes, I told you about that glucose changing the proteins in the hemoglobin and gives you that A1C reading. Well, it's doing it to all of your proteins. So, one of the things that it does with people with diabetes, and trust me, now that I'm going to say it, a lot more people on this audience are going to say, oh, yeah, yeah. Joint aches and pains, stiffness, inability to actually have the same suppleness in your joints that you did before you had diabetes. Diabetes does affect those tendons and those proteins in your joints, and that gives you the stiffness. So the yoga is going to get that little bit of suppleness back into your joints because you're exercising, you're actually stretching it out, and you're making sure that those tendons don't stay like that. So the answer to your question is no, I absolutely do recommend it. And hopefully, because it's now 9:30, otherwise I can keep going. I don't have a problem. I'm at home. Um, we have a question from Kalpana. Um, Thank you for answering my teenager's question about muscle mass being vegetarian because he was asking. Nope, You can absolutely be a vegetarian and still build a lot of muscle. Trust me on that. Big time. You don't need to be a meat eater. And there are many, many people who built lots of muscle without being non-vegetarians.
Okay. Does anyone else have any other questions? I don't see any other questions on Facebook. Anyone else have any questions on Zoom? If not, we can conclude. That was a great talk, Dr. Patel. It was awesome. A lot of good information too.
Hey, this is Dinesh here. I had one quick question. Is there, if you're above a certain age, is there an inability for your body to actually build muscle? Because I know as you age, you start losing muscle, but is there a way you can build, or it's just something you cannot?
Yeah, it depends upon what you define by building muscle. So if you're saying, okay, I'm 65 and then I want to kind of look like Arnie Schwarzenegger, and you can. No, and I didn't mean it as a joke. I think that it is possible. Building muscle takes a lot of skill and a lot of support. It does mean workouts, high protein diets for sure. I mean, you actually have to supplement with protein. You cannot do it without it. And this is one of the few times where, and even an endocrinologist will admit, that things that the world always wants to ban work. So growth hormone and testosterone supplementation will clearly make a difference, and that's been shown. Whether this is healthy or not is where people argue about. The answer is no. I think that you can build muscle at any age, but you have to work much, much harder for it. With aging comes a lot of changes. Men have a fall in testosterone, which is natural. There are some people who argue that that's not natural and therefore we should supplement men with testosterone. But it is what it is. If you look at lifestyle and life changes in men, and that's been done in many countries, men will lose testosterone progressively with age. And testosterone does impact lean body mass. We also become inactive. We push less weights. But for bodybuilding, you have to push weights, right? So cardiorespiratory fitness, elliptical and treadmills are not going to do it. You literally have to pump iron to actually build it. But you can do it, and you need to supplement with protein for sure.
Okay, thank you.
Okay, anyone else? Any other questions? Or can we? Okay. Dr. Patel, looks like everyone, you've answered all the questions. Thank you so much for an awesome presentation.
Thank you for asking me. I enjoyed it.